We are so excited to welcome you all to another inspirational and educational episode of Concorde Conversations, Season 3. Concorde Conversations is an initiative by Concorde Medical Group to educate, empower, and encourage our community about our health so we can all live to our fullest potential. Did you know that 1 in 10 people will develop kidney stones in their lifetime? In today's episode, Leaving No Stone Unturned, we're discussing kidney stones, preventions and interventions. Hi, I'm Dr. Catherine Weinberg, Director of the Adult Congenital Heart Disease Program here at Concorde Medical Group, part of Northwell Health, and we are joined by our outstanding colleagues from Northwell Health Lenox Hill and faculty at the Zucker School of Medicine at Hofstra University. I would like to introduce you all to our board-certified urologists, Dr. Lenny Glickman and Dr. Jared Winoker. Many of our Concorde community have submitted fascinating questions to ask our experts today. If you have any additional questions, please ask them in the chat box. We only have 30 minutes together, so we're going to go through as many as we can. Remember, we are giving general guidance. If you have a particular question about your health, we'd like to help you. So come in and talk to one of our exceptional Northwell physicians so we can answer your questions and give your health the attention it deserves. Let's begin. Thank you both for joining us today, Dr. Winoker and Dr. Glickman. Dr. Glickman, let's start with you. Can you describe the basics? Can you tell us the anatomy of the urinary tract system?
So when it comes to kidney stones, we're talking about obviously the kidney, but we're also talking about the ureter, which many people have not really heard of, but that's the tube that connects the kidney to the bladder. That's how the urine gets from your kidney, which is in your back, down to the bladder, which is in the pelvis. And then, of course, the bladder itself is part of the urinary tract as well, and the urethra, which is the tube where the urine comes out of the body. So that's where all the action is when it comes to stones in general in the urinary tract, whether they're kidney stones or stones in the ureter or even stones in the bladder.
Okay, Dr. Winoker, what are kidney stones?
Kidney stone is actually a concretion of compounds that are typically dissolved in your urine. And essentially, when they're at too high a concentration, they can precipitate, so solidify and form into actual stones or rocks. And these can occur really anywhere along the urinary system, as Dr. Glickman just described.
Okay, Dr. Glickman, what are the symptoms of kidney stones?
So classically, the symptoms tend to be excruciating pain in the flank, which is sort of the side of the back where the kidneys are. So typically it's isolated to one side or the other because you typically have one stone at a time, not typically on both sides. So whether it's pain on the left flank or the right flank, severe pain, which we call colicky pain, associated sometimes and not infrequently with nausea, vomiting, and more rarely, it could also be accompanied with infectious symptoms such as fever and shaking chills. But those are the classic symptoms of having a kidney stone.
When do you need to go into the emergency room and seek immediate attention, Dr. Winoker?
Classically, that significant pain that Dr. Glickman is describing is what often will bring someone to the emergency department or to the hospital. But of course, other concerning things are severe nausea, vomiting, inability to tolerate anything by mouth. By that, I mean unable to keep anything down. Fevers and chills are also concerning. Obviously, there's a lot of things that can cause a fever, but if you're someone who's actively passing a stone, or perhaps you have a history of a stone and you really have no other reason for why you're having that fever, that is a potential emergency, and you should be seeking care immediately.
Dr. Glickman, what causes kidney stones?
Many different reasons, ranging from a genetic predisposition, having a lot of family members in your family, extended family, who have a history of stones, that would put you at risk for that, and having underlying genetic causes for forming stones. In addition, very commonly, there are underlying comorbid medical conditions or other medical problems that you may have that are also putting you at an increased risk for developing stones. Sometimes it's dietary related, something in your diet is predisposing you to forming stones more frequently. So it's a whole range of different factors that can be playing a role in why someone might be forming kidney stones.
What are risk factors for kidney stones? Does diabetes or hyperlipidemia, high cholesterol increase your risk?
As far as things that you can't control, like many things, there is a somewhat familial or hereditary link, probably 30 to 40% of the time. whether that's truly genetic or we just learned dietary habits from our parents and our families, that may be the link. And then with regards to some of the more controllable or modifiable risk factors you mentioned, certainly things like being overweight and diet will contribute, and that's kind of ties into diabetes, which is a pretty big risk factor because some of the changes that happen to the body, especially with uncontrolled diabetes, they have a lot of changes on the urine that can allow you to have more of those stones to form. But really, there's a list of different disease processes that can contribute. They range from parathyroid issues. We see a lot of patients who have malabsorptive issues. So these are conditions that result in chronic diarrhea, inflammatory bowel disease, perhaps any prior surgery that required removal of a piece of the intestine, gout, and then even some medications you might be taking could be contributing to the stone formation.
What are the different types of stones that you can have?
So there's a whole range of different minerals essentially that can form stones in the urinary tract. Most commonly, it's calcium based, calcium oxalate specifically. But there are less common stone types such as calcium phosphate, uric acid, which is potentially linked with gout, as Dr. Winoker mentioned, and then even less commonly things like cystine stones or stones related to certain types of medications that some people take for their other comorbid conditions. So a whole range of stones, but most commonly calcium oxalate.
Dr. Winoker, how are they diagnosed?
Yeah, so typically they're going to be diagnosed based on imaging. So the most classic one we're going to be talking about is a CAT scan or a CT scan. Typically that's performed without any contrast. That's no medication going in through an IV in the arm. And that's by far the most accurate way of detecting and seeing stones. Whether we're searching for them because you came to the emergency department in terrible pain, or you're having a CAT scan for some other evaluation of another body part, what have you, and then they're found incidentally. There are some other ways we can detect it, other imaging types, ultrasound, what we call plain film x-rays. So these are lower radiation, just single shots of the body. They're definitely not as accurate as a CT scan, although they do have less radiation. And that's something we're going to more likely be using for someone who already has a known diagnosis, was previously treated, and then preferentially in someone who's younger, like children, or even pregnant women.
If you find a stone incidentally on another CAT scan, how do you treat them if they're not causing any symptoms?
Dr. Winoker mentioned a lot of the time people discover they have stones incidentally. They don't even know they have it. They don't have any symptoms. And so what helps guide our decision about whether something needs to be treated is size of the stone is a big one. So if a stone is relatively small, and by that I mean less than 5 millimeters, usually we recommend watching it. For reasons that we'll get into in a little bit. If they're larger stones and therefore less likely to be able to pass them should they try to pass, then in those situations we might recommend being proactive to avoid an issue down the road. So that tends to be one of the main decision factors is size of the stone. Less commonly, if someone only has one kidney for whatever reason and they have a kidney stone, and you may want to be extra vigilant about protecting that one kidney, you may want to be a little bit more aggressive in that scenario. So those are the main reasons for going after an incidental stone.
When can you pass a stone safely at home? Is it okay to sit it out at home as long as you can deal with the pain?
That's a good question. In general, yes, it is usually safe to pass a stone. We discussed some of those red flags that we discussed earlier, fevers, intolerable pain or inability to eat, vomiting a lot. Obviously, those are reasons you'd need to seek care and you might ultimately need treatment for the stone. But I'd say in general, for someone whose symptoms can be controlled, there's nothing to say they're at risk for infection or kidney dysfunction, we're generally going to give you up to about 4 to 6 weeks to try and pass the stone. Sometimes we'll just encourage fluids. There are some potential medications, but essentially it's going to pass. It's going to pass. I will provide patients with a relative likelihood when we meet and we counsel on the likelihood of being able to pass it, because a lot of it is tied into where is the stone located, what's the stone size, have you passed previous stones before, and then of course patient preference always factors into what we go ahead to do.
Dr. Glickman, why are kidney stones so painful? What can you do for the pain?
Yeah, so obviously that's the big thing when it comes to kidney stones is the pain associated with it. Really, it's because we're talking about visceral pain, sort of a pain of the organs, because what actually causes the pain is not the stone itself, but actually the fact that the stone is blocking the flow of urine. The kidney always makes urine, and if the urine has nowhere to go because there's a stone blocking that flow, you have a backup of urine into the kidney, which creates pressure in the kidney, and that stretches the kidney, and that's ultimately what's extremely painful. As far as what we recommend to control pain, actually, something that you may have right now in your medicine cabinet works pretty well for kidney stone pain, which is what we call non-steroidal anti-inflammatories, things like ibuprofen, Motrin, Aleve, Advil, not Tylenol, but all those other ones. They actually work pretty well for kidney stone pain. In some circumstances, we'll prescribe a narcotic, but those come with their own downsides, such as causing nausea, it can make you a little loopy. We try not to use that unless absolutely necessary. So, the run-of-the-mill Advil actually works pretty well. But if that doesn't work and you can't get comfortable, as we've been saying, you sometimes have to seek more immediate care, such as at an emergency room.
Okay. So Dr. Winoker, if you have small stones, can you get them before they get you? Can you dissolve stones with medications?
Yes, you certainly can treat stones up front. That's something that you'll want to have some counseling on the options that are available to you, and really what is the risk that that stone is going to become a problem, the asymptomatic one that's just kind of sitting up in the kidney. But the short answer is yes, you certainly can have it treated if you want. As for dissolving a stone, this is a question I certainly get asked every day. I'm sure Dr. Glickman does also. Everyone's always looking for a way that, can I do this without a procedure, but I don't feel comfortable with my stone just sitting there like a ticking time bomb to cause me a problem. And again, the short answer is no, because as Dr. Glickman said, the majority of stones are made of calcium, so they're like bone. They're truly like rocks that can't be dissolved. There is a small percentage of stones, probably about 10% of stones in the United States are something called uric acid stones. And these stones do have the ability to be dissolved over a long period of time. We use certain medications to adjust the acid-base balance in your urine to help do that. So it is an option, but further testing or having a specimen of the stone from some other point in your treatment would help us to direct that.
Let's talk about procedures. When do you need a procedure? When do you need an intervention?
Most importantly, as we've kind of touched upon a few times, is if you're in a particular situation where it's more urgent or emergent, such as having a stone blocking you that's causing, in the setting of an infection, fever, chills, etc., those are settings where we need to do something more urgently. Or if you have a large stone that may not be currently symptomatic, but given the size is very unlikely to pass on its own and likely to cause a problem if left alone, those are situations where we would consider intervening. And interventions really range from the less invasive to the more invasive. Least invasive would be a procedure where we focus sound waves from outside the body onto the stone itself, to using a telescope that goes in through the urethra or an existing hole that we can advance and see the stone that's causing the problem, and use a laser to break up the stone. We call that ureteroscopy with laser lithotripsy. And then one of the other sort of main treatment options that we use is going through the back percutaneously, where we make a hole through the skin, go through the kidney, and go right in and be able to see the stone. And that's what we use to treat larger stones that would be more difficult to treat with the smaller telescope, the ureteroscope.
How do you decide which intervention to use at the time?
A lot of it is about the stone size, also the degree of symptoms, what's going on. As Dr. Glickman alluded to, these are all minimally invasive procedures, but there are some that are more minimally invasive, so they're less invasive. And certainly we try and balance the least amount of invasiveness with our procedures relative to surgical success, or how well we can get you stone free after a procedure. So stone size, the location of the stone is also a factor we take into account. And then any sort of anatomical complexity, depending on the size and shape of the kidney, as I alluded to, the location of the stone within there. Generally, you're going to have couple of options for any stone type. You're kind of living on the boundary of different ones. So it's a very much a patient physician conversation, a shared decision-making process, balancing risks and invasiveness versus surgical outcomes. So, and then as far as things like laparoscopic open procedures, they're a bit outdated. There are some very rare cases where if you have a coexisting problem of the kidney, a blockage somewhere that needs to be repaired anyway, that might be one of those rare cases where we would consider something more advanced like a laparoscopic or robotic surgery.
It almost looks like you're playing video games when you do these procedures to me as a
It feels
cardiologist.
like it, it does.
Were you good at Space Invaders?
Yeah, I may be dating myself with what games I played, but all those years of hearing you shouldn't be playing video games.
No. Right. We can tell our parents, you see, it was all worth it at the end.
So is there any latest and greatest technology that you'd like to share with us?
We're lucky at Northwell at Lenox Hill that we have a lot of fancy toys that we have to play with, all the latest and greatest laser technologies. There are two main laser types that are available on the market, and we have both of them. So that allows us to really pick and choose exactly what would be best for your particular stone. And certainly we all have the latest and greatest telescope technologies that allow us to see these stones very clearly and be able to do the best job we can to get rid of these pesky stones from your urinary tract.
Yeah. And recovery after these procedures, how is it, Dr. Winoker?
You know, recovery after a kidney stone surgery is on the scale of surgical recovery, it's quite minimal. A lot of the symptoms you have after any of our procedures is not so much pain as it might be discomfort and bother. As Dr. Glickman alluded to about the pain you feel from a kidney stone, because it's a visceral organ. It doesn't have the nerves the way your skin and your muscle do that they would to an incision. So a lot of that irritated bother from putting instruments in there and treating stones and the inflammation, it's felt more like a mild urinary tract infection. It's kind of that feeling like you have to go to the bathroom, even though not much comes out. There can certainly be some burning with urination. A lot of these procedures, we leave a small, temporary, very soft plastic tube, almost like a little noodle called a stent. This is obviously a different type of stent than what Dr. Weinberg you might use in cardiology. This is a completely temporary stent that stays in anywhere from a few days to a couple of weeks after our procedures to allow for maximal drainage to the kidney, to allow for healing. And that's probably where most of the symptoms associated with our procedures come from, because it kind of tickles the inside of the bladder and tricks you into thinking you have to urinate when in reality your bladder is empty. But you know, we have wonderful medications to control that. And again, it's a short-lived, sometimes necessity that we have to leave that in some of these cases.
How successful are these procedures if you remove a stone by laser treatment?
So that's a very good question, because it's actually a bit of an ongoing conversation in the urology world. Part of the reason why is because it depends on how you want to define success. But meaning, do you want to define success as what are the chances that we clear every single little particle of stone from your urinary tract, or do we leave behind a little bit of dust or very small sub-millimeter or smaller than 1 millimeter fragments? So if we want to use the strictest term possible, that you have absolutely nothing left in your urinary tract, it's probably around 60-70%. But if we want to talk about leaving behind some very small dust that you should be able to pass on your own without much of an issue, no pain or anything like that, you know, it's probably maybe closer to 85-90%, maybe a little higher. So part of it depends on how you want to define success, but needless to say, it's pretty good. It's pretty high up there.
Should you use a strainer to collect your stones when you pass them?
It doesn't hurt. You know, certainly we give strainers to our patients who are, they come in through the ER or the office, they're trying to pass the stone. We'll certainly give them a strainer to try and collect it, or sometimes after some of our procedures like shockwave lithotripsy, we might have them try and collect dust. The reality is that the stone composition is not nearly as important as other parameters that, you know, we'll touch upon in metabolic testing, as there really are only so many types of stones, 3 to 4 that are even common, whereas there's a litany of reasons that could be contributing to each of those. So if we're not able to get a specimen from you or even get one from the operating room, it doesn't make that much of a big difference in reality.
When do you do a 24-hour urine test or other urine tests?
That's one of the mainstay tests that we use to determine why someone is forming stones and hopefully come up with a plan to prevent future stones from forming. A 24-hour urine collection test is where sort of what it sounds like. All the urine you collect in a 24-hour period is collected in a container. It's sent to a laboratory and they analyze the urine for all the different mineral components of it. And then based on the levels of those different minerals, and also maybe even most importantly, how much urine you made in a 24-hour period, that helps us determine what your stone forming risk. And generally these days, we recommend that in anyone who's really has formed a stone to get that information. Usually we get that after the stone has, if it's a symptomatic stone, we usually get that test after we've dealt with the symptomatic nature of the stone. If it's an incidental stone we're going to watch, we might do it at that time just to sort of get a sense of why you made the stone. So it is a very important, probably the most important test we have to determine why someone may have made a stone.
How often do stones recur?
Quite often. Someone who has formed at least one stone, it obviously tells us something about you, that your body and your kidneys have the propensity to form stones, and the recurrence is very high. We often will tell you you're a stone former now, or some of my other patients like to call themselves stoners, if you prefer that. In general, for a first-time stone former, I'll often tell people that you have about a 50-50 chance you're going to form another stone within the next 5 years, which is usually pretty alarming to them. And that doesn't necessarily mean you're going to have a symptomatic pass a stone, but that if you were to get imaging 5 years later, you have a very high likelihood. And that risk level can be even higher if you're someone who has risk factors, things we've discussed, multiple stones, strong family histories, some of those underlying conditions or dietary issues that are driving stone formation.
What can you do to prevent stones?
The $64 million question everyone wants to know once they've gone through the unfortunate experience of dealing with a stone. So again, the 24-hour urine can help guide specific, let's say, dietary recommendations, which are a big part of stone prevention, but probably general best practices, so to speak, is hydration. So stones have a hard time forming when the urine is very dilute. And the best way to dilute your urine is to drink a lot of water. So that's the big part of stone prevention is hydration. So as Dr. Winoker says, it's the number 1, 2, and 3 things that we would recommend that you do to reduce your risk of stone formation, and other things like avoiding too much sodium or salt in the diet, avoiding too much animal protein in the diet, which tends to be our Western type of diet. So those are the main kind of broad things that you can do to reduce your risk of making more stones in the future, but sometimes fine-tuning that to your individual body is based on the 24-hour urine collection, which gives us even more detailed information about you.
So how much water should you be drinking every day, Dr. Glickman?
It's at least 10 to 12 cups a day. And for someone who's maybe not used to drinking that much water, that sounds like a lot, but to the best that you can drink as much as possible, more than you normally drink, that's probably the way to go. An easy way to tell how hydrated you are is to look at the color of your urine. So if you're a little underhydrated or dehydrated, then your urine is going to look more yellow. And so you will really want to get that to look almost like water, as clear as you can get it. Then you know that you are doing a good job in hydrating yourself.
Let's talk a little bit about supplements. Does calcium, vitamin D, any of those cause kidney stones?
The short answer is they can certainly drive it in someone who's predisposed, though often the doses you're taking, and a lot of times things like calcium and vitamin D supplementation for bone health is often prescribed by another physician, and they're rarely at doses that are truly driving it. Now, excessive doses, people self-medicating, some of these things, calcium, vitamin D, vitamin C also drives oxalate as a contributor, so certainly excessive levels of that can be driving it. But this is where the beauty of the 24-hour urine is that if you are taking it, that supplement that is, and we're checking your 24-hour urinalysis somewhat regularly, and we're also monitoring for new stones or the growth of existing stones, we can really see how much is it playing into account, and we can kind of start to tailor your diet, your supplement, your medications to the relative activity of your stone disease.
Are there certain foods you should not consume because they'll increase your risk of developing stones?
We keep going back to the 24-hour urine because that's really going to tell us specifically in your body which foods might be your problem. So things like oxalate, like Dr. Winoker mentioned, that those are found in certain green leafy vegetables and certain teas, certain beets, things like that, where if we can find a clear correlation between what we're seeing in your urine tests and what you're eating in your diet, we can tell you, okay, you really have to cut back on those, 20 pounds of spinach that you eat every day. We can tell you to cut back on that specifically. Generally speaking, though, again, avoiding too much salt is always good, and you want to try to really keep a close eye on how much salt you're taking in, because we have a tendency, especially in New York, we eat out a lot and you have no idea how much salt is being put in your food. So if you take ownership over your consumption of food by cooking for yourself and just being mindful about what's going into your food, or just sticking to more sort of the, as Dr. Winoker mentions, the outside aisle of the supermarket where you stay away from processed foods, you can stick with healthier foods with lower sodium content and other junk that probably isn't good for you anyway. Those are all things that can only help you.
I want to add, I think Dr. Glickman makes a really good point about salt or sodium. I think sometimes there are some people who don't realize that salt is the same thing as sodium. So that's the first thing. And then most people who say you need to be having a low salt diet will often say, well, I hardly add salt to my food. And we all know it's rarely from the salt shaker. It's the processed foods, things that come in bags and chips and cans, and the use of sodium as a preservative. So if you're really trying to adopt a low salt diet, like Dr. Glickman said, it's controlling, looking at labels, cooking for yourself, and really trying to clean things up. Because really it's a teaspoon of salt a day, which seems incredible, but that's really the recommended daily allowance. So you need to be below that for both kidney stone health, cardiac, and just general wellness.
Yes, I agree. So there's a question in the chat box. Can Flomax be used as a prevention medication? Dr. Glickman?
Flomax is one of those medicines that people who've had kidney stones may be familiar with because it's frequently prescribed. Unfortunately, it's not really used as a preventative medication. There is no real role for that to say that if you take this, you won't form stones. What it sometimes is used for, and the data is a little bit mixed about how helpful it is whether or not it may help you pass a stone if you're already trying to pass a stone. The theory is that perhaps the Flomax or tamsulosin, which is the name of the generic medication, maybe it's going to relax the ureter a little bit, the tube between the kidney and the bladder. And if it relaxes that tube a little bit, maybe it'll allow the stone to pass more easily. So sometimes people are given it when they're passing a stone, but unfortunately, it's not going to prevent the stone from forming.
Last question. If you had one action step to improve your health and start today, what would it be? Dr. Glickman, do you want to go first?
Sure, I'm going to guess what Dr. Winoker's is going to be, but I would just say hydration. Hydration is really the biggest thing that you can do to protect yourself from forming stones. If you're a stone former, it's going to help reduce the risk of forming new stones. So hydration, and that's sometimes hard to do when we're all really busy and we have barely enough time to eat and drink during the day, but that's really the important thing that you can do.
Okay, Dr. Winoker, what do you think?
He said it, took the words right out of my mouth. Whatever you can do. If you can't hit that 10 to 12 cups, it's a lot like going to the gym. Just doing something a little bit more than you already are is going to help you, and it's going to make up for a lot of other indiscretions because it'll keep that urine nice and dilute. So drink up.
So drink your water. Well, thank you everyone for joining us for another inspirational and educational episode of Concorde Conversations. A very special thank you to Dr. Winoker and Dr. Glickman for joining our conversation. We appreciate their ability, their expertise to educate, encourage, and empower our community. As part of the Concorde community, we hope you will share in our mission. Please pass along our emails and webinar links to your friends and family. In addition, please subscribe to our YouTube channel. We know you have additional questions about your health and we want to help you. So come in and speak to our extraordinary Northwell physicians about your health. We care about your health. We care about you. Thank you so much for joining us today.